Okay, I assume you can see my first slide. Thank you for that kind introduction, Mari. Yes, my disclaimer is that I am an immunologist, not a veterinarian. I'm part of the Yale Cancer Center here. And as you pointed out, I've had a long interest in understanding what triggers autoimmunity. In fact, most of my scientific career has been involved in looking at diseases like lupus, systemic lupus erythematosus, and type 1 diabetes. These are diseases where your immune system essentially attacks your own tissues. So to me, this is the essence of cancer immunotherapies in a manner in which we would prefer, or if we could program our immune systems to attack self-tissues, these self-tissues being cancer, that would be an ideal therapeutic strategy. And as we all know, immunotherapies, checkpoint inhibitors in humans, for example, has really changed the landscape of cancer immunotherapies. I would be nothing without a lot of bright people and input from around me. My lab is listed under me. Dr. Doyle manages most of this clinical trial that we've been doing. But this really could not happen without a lot of collaborative interactions with key veterinary oncologists, notably Jerry Post, some of you may know. He was involved in our very early trials. He trusted these after we have published these in mouse models, by the way, Mari, but our impending publication in canine cancer, which I'll present data for today, hopefully will be published soon. So Jerry Post was instrumental early on, as well as Dr. Jackson here in Norwalk, Connecticut. Carmen Booth is a veterinary pathologist here at Yale. There are a number of other veterinarians around the country who have participated and referred many or all of their appropriate cancer patients to us in past years and months. Notably, some other individuals, Mike Rosa and Rick Niesel, have been highly supportive. And then I get reality checks from a number of veterinary oncologists, notably Phil Bergman and Stu Helfand, who have been training me in the ways of veterinary oncology clinical trials. Mari and the Canine Cancer Research Alliance have been quite supportive in our group, as have a number of other, the NIH funded early studies in mice, as well as the Alva Greenberg Foundation. So I'm going to take about 20 minutes, and as Mari said, please interrupt. I'm here to actually learn more from all of you than potentially what information I may impart to you. I don't have to remind any of you the importance of looking at cancer in dogs and in cats. And this is a Scientific American entire issue several years ago that came out about looking at companion animal diseases and how they can be quite helpful in understanding human diseases. Again, a New York Times Sunday magazine that came out about 3 years ago emphasizes this. Again, these are things that I don't have to emphasize to any of you about how similar canine cancers are to human cancers in a number of these tumor biomarkers, the genetics of them, the molecular targets, profiling, therapeutic responses are highly similar, and elements in the biology of metastasis as well. So, you know, I really look at this. I'm primarily a human immunologist and a human cancer immunotherapy driven person. But again, the dogs are perfect. And I'm a dog lover as well. 3 of mine are wandering around the house. You may see them in a little bit. Canine cancers have contributed a great deal to understanding and therapeutic strategies in human cancers. Again, most of you are probably aware of the detailed studies regarding bone marrow transplants, both autologous and allogeneic, limb-sparing surgery and osteosarcoma, drug toxicity testing, and then some other therapies that have been utilized in human cancers. Humans, as we all know, or human cancer therapies are directly translated into our dog therapies. A number of chemotherapies, which I'll elaborate on briefly in a minute, radiation therapy, and I know it will be quite soon that checkpoint inhibitor therapies will infiltrate therapeutic strategies in canine cancers. Again, many or actually most chemotherapies get translated from man to dog. And a list of them, there is only one real dog-specific chemotherapy that we all know about. So in part, our strategy is in understanding immune responses to what are called neoantigens. These can be things like either post-translational protein modifications in various tumor proteins, or even genetic mutations that causes a change in how tumor proteins look. We know that they drive immune responses in humans. I suspect they do in dogs as well, although much less is known about that. This is a manner in which these things have been found in human cancers. Are you able to see my pointer, by the way, if I use it?
Yes.
Great. So in humans, one takes a tumor sample and basically does a whole lot of biochemistry to know the sequence of various tumor proteins, and then one can then synthesize those mutated antigens and use them as vaccines. This has been done in a number of different cases with varying success. This is one study from humans that illustrates the importance of new cancer proteins that, now, as we all know, cancer is a very dynamic process. Tumors change greatly over the time that they're in the host. Individual tumor cells within the same tumor can be very, very different. So this is a group of, all you have to really do is look at the blue squares with the double stars there, and these are humans that make immune responses. These happen to be T lymphocyte, so particular type of white blood cell that attacks tumors. These happen to be T lymphocyte responses to new tumor antigens that arise in patients over time. And of course, immune-based therapies like checkpoint inhibitor therapies have evolved to take advantage of these observations and keep these tumor-specific immune responses in the right places in the tumor microenvironment, so hopefully they can kill off tumors, and in fact, that's what they do. All right, so we're interested, I won't go through all of the history here, but we're interested in this particular family of tumor proteins. I will elaborate a great deal on them today. These are known as ErbB family proteins, and they encompass a protein called EGFR, HER2 or ErbB2, HER3, and HER4. They're found on a number of human and canine cancers. This is a list of the human cancers that they're found on. This is EGFR. It's on breast, ovarian, renal, lung, head and neck, colorectal cancer, various gliomas, etc. HER2, of course, notably on about a third of breast cancer patients, a particular subset of breast cancer patients, as well as ovarian, renal, lung cancers, and then HER3 and 4 again expressed on a number of human cancers. These are remarkable in that they're highly similar between these four family members. You can see they all have common domains in them. They have parts that stick outside the cell as well as inside the cell. The part inside the cell, of course, translates signals via tyrosine phosphorylation to the nucleus, and I'll explain some of the biology here. But the unique thing about this family of proteins is that they form what is called heterodimers. They form two of the individual proteins linked together on the surface of the tumor cell. And again, this is a dynamic process over the growth and the lifespan of a particular tumor. So, and again, this is constantly changing, constantly evolving. A particular tumor may have a lot of EGFR homodimers, but over time, EGFR may pair with any number of proteins in that family, including HER2 and HER3. So you get really a mixed collection of these signaling molecules that assemble on the surface of the tumor. Now, we all know it's the tumor's job. It's the tumor wants to survive. And of course, the dynamics here are in therapeutic strategies that are trying to kill off tumors at the same time that the tumor is mutating and changing and trying to preserve its existence. So this is one manner in which humans and presumably dogs become refractory to various chemotherapies. For example, ErbB, which is one monoclonal antibody binding EGFR, if it sees EGFR in the context of HER2, it is much less effective in inhibiting signaling through this heterodimer as opposed to a homodimer. So again, the tumor is always seeking ways to avoid immune-based therapies. So we picked on these families of proteins for the simple reason that monoclonal antibody therapies, notably things like Herceptin and ErbB, and there are many others, target these proteins in humans, and they're known to be quite effective, actually. This is sort of a visualization of what's happening on the surface of the tumor cell. You've got these monomers of EGFR, HER2, 3, and 4. Their ligands will come and attach. They form these hetero and homodimers. One gets a fairly complicated signaling pathway that happens inside the cell. It finds its way to the nucleus and then tells the tumor cell to survive or to not die or to break off and metastasize or even grow. These are growth factors, of course. So very simple biology here. So the existing therapies are based on monoclonal antibodies. These are antibodies originally made in mice. They've been humanized such that humans don't reject them as being foreign. And their role is to either block signaling through these receptors, of course, or either bind them and kill tumors directly in a number of different ways. We know a lot about the structure of these proteins and the whole family. And I won't bore you with a lot of the strategy that we went through early on, but suffice it to say, we looked carefully at where ErbB, which is cetuximab here, where it's binding this family of proteins. We picked a site quite adjacent to where ErbB binds, and we started making synthetic peptides to see if we could enhance or trigger immune response to this EGFR protein shown here in blue. I will tell you that we experienced many failures in seeking the right segments and the right proteins or the right peptides of this protein to trigger immune response. Of course, I'm only going to tell you the successes here today. So we were assisted by the fact that all of these proteins of this family look very much the same in composition. These are amino acids that make up a particular domain on the EGFR, HER2, and HER3 proteins. You can see, at least in dog proteins in this family, this region is completely identical. So why is that important? Well, strategically, what we wanted to do in using this simply put, as a vaccine, we wanted to trigger antibody responses that would not only bind EGFR, but bind HER2 and HER3, such that when we get this heterodimerization, these antibodies that arise naturally will bind this heterodimer, this one, any of these combinations, if the antibodies can cross-react and see those parts of the protein on living tumor cells. So that's the strategy. We went through a lot of sequences like this, trying to find out the ones that gave the best immune responses in both antibody and T cells. This is the one that we've chosen. It has a lot of homology also with human and mouse regions in this particular site as well. For example, the dog sequence has only one amino acid different between human and mouse. So we also designed these studies to hopefully be translational, hopefully in the future, into human immune-based therapies in a similar strategy. Again, these proteins are highly homologous between human HER3 and HER2, as well as canine. So they look the same. An antibody that binds one will bind all three, hopefully on the tertiary and quaternary structure of these proteins as they sit on the surface of tumors. We published this as we first did it in mouse models. This is that paper. And the conclusions of that is this peptide that I just showed you the sequence of does trigger an effective immune response to these three proteins. Those antibodies kill tumors that have EGFR, HER2, or even HER3 on their surface.
Oh, look. Here.
Sorry? Okay. Dogs are starting to ask questions. This is an illustration of what happens in the mice. Antibodies bind these red.
This is terrible. I can't.
These red columns illustrate that the antibodies bind.
No, don't do that.
So this is a figure that illustrates, so trastuzumab is the same as Herceptin. This is a control antibody that you can see shifts this group of cells, tumor cells, from the left to the right, showing that the tumor expresses it on the surface, and it's bound by this therapeutic antibody, again used in humans. And these are antibodies made in mice that do essentially the same thing, not as aggressively as they do with this. But you have to remember, this is a single monoclonal antibody, whereas this is an immune response from whole serum from a recipient that has been vaccinated. So you wouldn't expect the the binding of these to be quite as strong as a single antibody that has been designed for this. This column on the right shows that tumor growth is inhibited in recipient mice. This is happens to be a liver cancer that expresses EGFR. So it has therapeutic strategy. So you're all here because you're interested, of course, in the canine studies, and that's what I'm going to turn to now. These originally were a phase 1 group of studies in companion animals. We started in Norwalk, and again, with the help of Jerry Post. You can't do anything in dogs these days without being picked out by various media outlets. Jerry and I were interviewed on MSNBC about this program early on. It's a strategy similar to what we did in mice, using EGFR proteins, this peptide, 2 vaccinations, and this is what it's composed of. It's a canine EGFR-peptide. It's 20 amino acids long. We mix it with LymeVax, canine Lyme disease vaccine, and a commercially available adjuvant called Montanide ISA 51. So you may be wondering why we add a little bit of LymeVax into this formulation. It turns out that we wanted to also know if dogs were immune compromised, potentially, or and have a second immunologic marker to follow both the anti-tumor response and the antibody response to Lyme vaccine. So if they were negative immune responses to both, we would conclude that potentially the dog is immune compromised in a particular way, be it by chemotherapies or genetically. The dogs were boosted at day 21 as above, and then our role is to take peripheral blood, assess antibodies and T cells, and tissues as well. This is a group of our patients from our clinic in Norwalk, Connecticut. This is a great project. I've had a lot of fun doing it down there. I get to meet lots of great moms. Canine tumors express ErbB family members, including mammary carcinoma, pituitary, osteosarcoma, glioma, hemangiosarcoma, lung, and a number of others, including things like anal sac carcinoma as well, transitional cell carcinoma in dogs. There are many of you that might think osteosarcomas, which in fact are our largest group of dogs. There's some controversy about how they express various levels of EGFR or HER2. That's not a topic that will completely resolve today. One thing that my lab is very good at is staining EGFR and HER2 and these other family proteins on tissues and in various other sites. I can tell you that the field is really strapped by the lack of good probes, good antibodies that bind and show these proteins by immunohistochemistry. And then there are other studies primarily done in humans that illustrate that even tumors that have very low levels immunohistochemically detected, very low levels of EGFR or HER2, still have very good success with drugs like Herceptin and Erbitux. So it means that even an EGFR low tumor can have therapeutic benefit through immune-based therapies, antibody-based therapies. These are a couple papers from the veterinary literature illustrating the expression of EGFR on osteosarcomas, both messenger RNA as well as protein. I won't elaborate on those. That's all published stuff. I've gone through the sequences already. I think I'll go get to the data. So this is collectively an antibody immune response that binds EGFR. These are now from the first 8 patients that we did. So this is really a proof of principle early on. We're now in over, 400 patients, and I'll get to those. I'll just summarize some of them. You can tell from this is really just the intensity of antibody responses between individual patients. You'll see that individual patients can respond very differently to the same vaccination. This is largely mediated by individual genetics of the host. These are all positive. They're at least 4-fold above pre-immune bleeding, and some can be as much as you can see, greater than 10, 20, or 30-fold above pre-immune serum levels. So these are essentially studies we do in the lab to show binding to EGFR. And then this is another group in the lower right. Again, it was a different formulation than the one I'm showing on the left. We were trying to optimize strategies and conditions and even dosing levels, actually, of this vaccination strategy. And I'll tell you that about 80% or more get 4 to 5 or greater fold increases in anti-EGFR antibody responses within about 3 to 4 weeks and 2 vaccinations with this formulation. Again, a third group, collectively, now I'm showing about the first 100 or so patients. So collectively, the antibody responses are very statistically higher compared to pre-immune samples. This lower right-hand panel of responses is to the Borrelia antigens that are found in Lyme-Vax. So again, this illustrates that most of these dogs had fine immune responses. Two of them probably were partially immune compromised, number 67 and 70, that have much lower responses to this control protein that we have in the vaccine. As it turns out, this is probably also a toll-like receptor agonist, so it actually does even enhance immune responses to the EGFR protein. So what do the dog antibodies do? Well, much like the mouse response, they bind tumors that have EGFR on their surface, or HER2. That's comparing red, which is a pre-immune dog serum, to its post-immune response in both of these cases. So it binds living tumor cells that have either EGFR or HER2. The way that human therapies, the monoclonal antibody therapies work, or one manner in which they work, are in blocking signaling through this complex of EGFR or HER2. That, in fact, is what the dog antibodies do. So if one compares the blue panel, so this is sort of an interpretation of the gels that we use to measure signaling through these receptors. The blue being an uninhibited signaling response in the tumor cell. And then when one adds immune dog serum to this biological system, the signaling goes virtually down to zero. This is in either human or dog cells that signal through the EGFR protein. So again, proof of principle that the antibodies that were able to be elicited by vaccination have the biological activity that resembles Erbitux or Herceptin in blocking signaling through this pathway. So strategically, do they find their ways to the tumor? Answer is yes. This is a patient that we have down in Norwalk that did not survive its bladder cancer. We were able to get tissues and did post-mortem and necropsy on these tumors. And this is, again, from an immune dog. And this glowing green stuff is the deposition of antibodies that found their way to the bladder cancer compared to adjacent non-tumorous bladder tissue in the same animal. So again, suggesting that vaccination triggered antibodies that found their way to the tumor. Canine osteosarcoma, a very similar biological assay. These now are just osteosarcoma tissue samples that we processed in the lab and stained with either pre-immune or immune serum. This is Erbitux as a control, showing pretty significant binding in these canine osteosarcoma cells. And then the green signals that one sees in these four tissues illustrates that immune dog serum, again, binds cancer in these tissue sections. You'll note that number 36, which is a pre-immune serum from a host, binds significantly as well. And I'll tell you that we sometimes find, I would say probably 3 or 4 in 100 hosts have an antibody response to EGFR or one of the other ErbB family protein members without vaccination. So this illustrates the earlier point that I made, and we would ascribe this response to probably immune responses to neoantigens, to mutant peptides of EGFR that triggered an immune response in a few hosts of cancers. Again, this is a similar section as what I showed earlier with bladder cancer. We were also interested whether CD8 killer T cells infiltrate these tumors as well. All of these green dots in this tumor section are CD8 T cells, so the answer is yes. Vaccination also triggers CD8 T cell responses. So strategically, how do they do in patients? This is Cody, one of our early patients that we saw down in Norwalk. Cody had amputation, as you can see, 4 to 5 rounds of carboplatin, as I recall. Had residual metastases found in the lung, and this was as of April 2018. Right after we got this X-ray done, Cody was vaccinated with our therapeutic, and by January of 2019, that tumor had resolved. We have a number of other patients in which we do have good imaging support for resolution of other lung mets. We're actively interested in recruiting patients with lung mets to see if this therapeutic strategy is particularly effective in either creating static, non-growing lung mets or even resolving some. And this is a second patient. We have a group of 5 or 6 now in which we have very good imaging documentation of lung mets resolving. And again, this is with survival. Unfortunately, Cody passed away just this past week, not from osteosarcoma. Unfortunately, Cody had a hemangiosarcoma that arose on his liver, and it appears that's as a secondary cancer is what caused Cody's demise. So overall survival, we're just now beginning to go through some of the details. This is sort of the gross survival curves that we see. So we've compared patients with amputation and carboplatin alone versus carboplatin followed by vaccine or no chemotherapy but amputation. So this black curve is what I would consider what we're used to seeing for conventional chemotherapy, with median survival at 12 months of about 30 to 40%. This is found in various publications, of course. So adding vaccine to that gets us to in and around 60%, slightly lower. We're still analyzing ongoing patients. Even though we're in this, we're 3+ or almost 4 years into this therapeutic strategy. The formulation has changed a bit over the course of the formulation of the vaccine has changed a bit, in part to try and optimize immune responses. But this is what we're seeing. This is a group of, I believe, 85 patients now with osteosarcoma. So where are we going from here? Well, I would like to think that this therapeutic strategy could potentially be adjunct to a number of other strategies. For example, this prior study that I'm sure most of you are aware of, this is the HER2 listeria vaccine that has been used in osteosarcoma. We all know, or probably familiar with some of the outcomes of that. But immune responses to this family of proteins, at least in humans, EGFR, for example, increases the sensitivity and the efficacy of radiation therapy in a number of cancers. I just cited one here. But the literature really is, there is a lot out there that illustrating the use of either Erbitux, Herceptin, or even checkpoint inhibitors that enhance either other tyrosine kinase inhibitor therapies or enhance radiation therapy. These are a couple of new articles, fairly new articles about neoepitope vaccines, which is essentially the category that I put our therapy into. So where are we going? Well, we've established that we can get immune responses, both antibody and T cell, to this family of proteins and bind all three on plastic dishes, on living cells, and in living hosts. So we're able to break immune tolerance. I'm an immunologist. This is not a big trick for an immunologist to try and break tolerance to a number of self-proteins. They kill tumors both in vivo and in vitro. The in vivo part is primarily supported by studies, significant studies in mice, the in vitro in both mouse and dog. In our dogs, we don't see any effect on behavior, appetite, energy. This is really a simple subcutaneous vaccination, takes about 10 seconds. We do get what many of you know to be a sterile abscess. In about a quarter of our recipients, this can be anything from a small marble-sized inflammatory nodule right at the site of the vaccination. The vaccine does not go systemic. It's perfectly sterile. It's not an infection. When it's sampled, it's primarily all neutrophils. It's all immune cells that come to the site trying to digest the vaccine and leaving to secondary lymphoid organs to engender then an immune response. As an aside, you know that when you get a vaccine in the shoulder, for example, it may be sore for a few days or even a week. That is actually a good thing. That means inflammation is happening at the site of the vaccine. Immune cells are there. They're spitting out cytokines. That's the cause of the soreness. This is akin to what we're seeing in some of a fraction of our recipients. You don't need to get this sterile abscess to get a good response. It turns out that most of the dogs that do get this have among the highest antibody titers to the peptide and to the protein. But therapeutically and with clinical outcomes, we have not yet correlated how much of a response leads to a good clinical outcome. Of course, the significance here now, unlike using drugs like Herceptin and Erbitux, where you need to continuously infuse the patient every 3 to 6 weeks because the antibody half-life in recipients, it just goes away. In this type of active immune response, there's long-term immunity throughout the lifetime, just like any other vaccine. I might say also, we've looked at recipients of the vaccine. We've looked at every tissue looking for untoward autoimmune responses in other tissues. We've looked at brain, heart, lung, liver, skin, everything essentially here at Yale from recipients of our vaccine, from our local clinic in Norwalk, Dr. Post's patients. We see no immune complexes or antibodies depositing in other tissues. So I mentioned we're interested in patients with lung mets as an additional group to this study. And we're also trying to recruit patients to get vaccine either prior, at least in osteosarcoma, prior to amputation surgery or prior to chemotherapy. And the rationale for this immunologically is that an immune response can arise within 3 to 4 weeks. Both B cell memory and plasma cells, these are terminal stage immune cells that are not affected by chemotherapies that wipe out bone marrow, for example. Plasma cells and memory B cells will remain there. We know this. So love to hear some comments from the vet oncologists, if there are any here, or even the other cancer immunology investigators that may be here as well. With that, I'll open it up to questions, if there are any. Let me get out of this. Let's see, stop share. Okay, any questions?
You can also use the chat box, chat and type in your questions as well.
Happy to carry on a dialogue or discussion about other questions. I will say that we're just now analyzing our hemangiosarcoma patients. That, as you can, I suppose, appreciate, is a much more difficult subset of patients to analyze based on a number of factors, where the extent of the the tumor growth, particular organs that may be involved, surgeries, clean margins or not. So someone's asking when the vaccine will be available to patients again. As some of you know, we're seeking USDA licensing. We hope to be through that within the next month, perhaps longer. That's an active, ongoing process. We were originally approved through other mechanisms, FDA and NIH-based mechanisms, to send this vaccine out to any licensed vet office. As it turns out, and as we found out through a number of channels, there was an objection made to the USDA, and so we essentially early on were in violation of some licensing approvals, which we're seeking now. So we hope for that to be out. We hope to be up and at it again, hopefully soon. Are we considering using the vaccine in conjunction with checkpoint blockade? Absolutely. In fact, we wrote a grant with an investigator here at Yale, Li-Ping Chen, to use experimental checkpoint inhibitors in conjunction with and without vaccine therapy. The immunology associated with wanting to do that is much in place. So the way we envision this happening is the vaccine triggering an anti-EGFR-B and T cell response that is maintained by checkpoint inhibitor therapies. So there's great rationale for wanting to combine this vaccine with other immune-mediated therapies. We're also interested in future groups in this canine study is knowing whether the vaccine improves radiation therapy or other chemotherapies. Let's see. After licensing, do we intend to continue to distribute to all licensed vets or limit to oncologists? The enrollment is absolutely the same, whether the dogs are being seen by general vet practices or vet oncologists. We do need a pathology verified tumor among the EGFR HER2 family. So it won't matter as long as the criteria for getting into the trial is satisfied. Have we established cell lines from osteosarcoma dogs and then vaccinate, follow their humoral and T cell responses over time compared to pre-treatment in vitro? Stuart, this is a great question. Unfortunately, we have not been able to do that from a single patient. We have begun to look at CD8 T cell responses. As you may know, the amount of blood required to establish CD8 T cell lines as well as tumor lines is not trivial. We do see CD8 responses to various EGFR-peptides, and we also see a phenomenon called epitope spreading. For the immunologists here, one knows that, and this is a function of why our immune systems work so fantastically in clearing things like pathogens, things like COVID, or bacterial infections, is that our immune responses expand to many proteins, many determinants on a protein over time, and that's how we effectively eliminate pathogens, and that's how we effectively eliminate tumors as well. So in successful tumor therapy, we probably get a degree of epitope spreading, and those are things that we can measure in the lab. And we would love to in long-term survivors of those who receive our vaccine. Let's see. Generate potentially an initial type 1 response, long-term memory. We can't fully comment on type 2 responses, We do see long-term memory now in long-term survivors. In patients that have received vaccine, I would say that more than half have a robust immune response after 12 months. Some that don't, we've boosted a third time, and we will see an increase both in antibody and T cell responses. Are humoral responses monoclonal or polyclonal? They are polyclonal. In fact, as I mentioned, Stuart, there is some epitope spreading. We've seen antibody responses to migrate to other sites on the EGFR protein. That's actually, if you're really interested in that phenomenon, you can look up some of the old literature that I've published. Just Google or find your favorite database to pull up my old papers in autoimmune diseases that illustrate, some of the reviews I've written illustrate how that phenomenon works. Efficacy with mast cell tumors. We do have a number of dogs with mast cell tumors. I'm trying to stick to data that are statistically significant. And at the moment, we're focusing on osteosarcoma and hemangiosarcoma. We do have a growing number of mast cell tumor patients, as well as anal sac carcinoma, transitional cell carcinoma. But again, I don't want to be criticized for lack of power statistically in any of these studies. I'm trying really to do them correctly, publish the data that we know are statistically valid with 95% confidence intervals, which is the data I just showed. While immunotherapies appear useful in conjunction with traditional radiation or chemo, is the reverse true? Or would immunotherapy do better without the patient having already chemo that might inhibit effective immune response? A great question. There are two lines of data, of strategy that can be answered by. Some have thought that irradiating a tumor or killing by other mechanisms, chemotherapy, may release tumor antigens that actually enhance local tumor-specific microenvironment, B cells and T cells. So by killing and releasing tumor antigens, that may be a way actually for the host to boost its own immune response. That's supported by some therapeutic strategies which are continuing. So for example, you know about the organizations out there that are collecting tumor tissues from hosts, making an extract of tumor and injecting it back into the host, to the recipient. The same dog that donated the tissue is receiving an extract. I can only refer you to the literature to which those companies and that data, this has been done in human cancers as well, or a collection of tumor proteins in a cocktail of peptide, tumor peptide-based therapies. This again is from Stuart. Multiple freshly drawn blood would need to be used to follow immune responses as a function of time. You're absolutely right, Stuart. Cryopreserved lymphocytes usually perform poorly. That's our experience as well. Although if you're pretty good at freezing peripheral blood lymphocytes, they can sometimes be triggered with the right peptides and multiply along with cytokines in the cocktail in plastic dishes, and we can sometimes get them. Can we postulate why Cody's anti-EGFR responses to the osteosarcoma were not protective against hemangiosarcoma of his liver? Stuart, you drove through the surface of that data very articulately. we were wondering exactly the same thing. Cody's owner actually is in the middle of getting necropsy done, hopefully to send us part of the hemangio tissues that may have caused demise in Cody. We will know hopefully soon, in the next month or so. I don't know when we're going to get the tissues. Excuse me. We'll know if antibodies migrated to the site of the hemangiosarcoma as well, or if they did not. Hemangio, as you know, is a very aggressive tumor. It's the toughest one that all of us face. I know all of you vets out there, although I'm not a vet or a vet oncologist, this is drilled into my head how difficult therapies are for hemangiosarcoma. So I think potentially hemangiosarcoma that emerged in Cody after osteosarcoma, potentially those heterodimers of EGFR proteins, or they mutated to allow escape from immune recognition. I would love to know the answer to that. And if we can stain individual tumor sites and microenvironments from Cody, and we're certainly going to try that. So hopefully we can answer your question, Stuart, with real studies in the lab, hopefully soon. Can we combine EGFR-peptide with other tumor antigens to increase efficacy, not just checkpoint inhibitors? Yes, absolutely. I've had offers from others who are investigating other tumor proteins that are associated with this same family of tumors. We also want to know if things like other tyrosine kinase inhibitors specific for this family of proteins, gefitinib, for example, whether they synergize with this vaccination strategy. From James, are there studies quantifying antigen on metastasized cells versus primary tumors? Do they also tend to express EGFR, or would different antigens be more effective against metastasis? Another great question, James. Thank you. That's been addressed partially in some of these other studies that have looked at EGFR, both protein and messenger RNA, on tumors from various sites. I'll refer you to those proteins from John Kana and other groups. There was a group in the Netherlands that published looking at message and in protein in dogs from tumors extracted from various limbs or from lung or from other metastatic sites. As it turns out, there's a little bit of wiggle room in EGFR expression. To me, the data I don't yet think are convincing or consistent to indicate whether a lung met, for example, expresses more or less EGFR. We do know that metastasis in general is directly correlated with a higher level of EGFR expressions in various tumors, or HER2, for example, in human breast cancer. What's the planned procedure for getting final approval from the USDA, not just provisional, pivotal study plans? Yes, they're going to dictate, I guess, what we need to get more than just provisional licensing. You know, honestly, there are two things that I want to optimize here. One is reducing this annoying sterile abscess response. These things keep me awake at night, honestly. I get lots of emails previously from moms and dads who have this huge bump, and they may open and they may leak fluids. I'm trying to eliminate that. We're trying to tweak the formulation a little bit to reduce that from happening. I can tell you, in fact, maybe some of you can weigh in on this. Our clinic down in Norwalk does subcutaneous vaccination right between the shoulder blades on the back or the back of the lower back of the neck. they see among the fewest sterile abscesses, almost none, probably only 5 to 10% of their patients actually get any inflammation. I'm worried that doing it on the side of the neck actually some of the vets may be injecting subcutaneously into some muscle or other subcutaneous tissue that's amplifying this response. I don't know if any of you have experience with that. I have spoken to some veterinarians in Texas and Arizona that tell me that use actually rattlesnake vaccine. This is a reasonably common vaccine used in the South and the Southwest. They tell me that they get sterile abscesses with every injection of rattlesnake vaccine. They don't tend to worry about it. Again, we're getting such good immune responses. I, in part, hate to sacrifice that response that we're getting that's leading to pretty good clinical outcomes in patients. We now have patients that, so Cody survived nearly 3 years after the onset of his osteosarcoma. After the onset of the hemangio really is when his health started to decline. But in fact, his owner tells me that Cody was quite active. It was a fairly acute onset of death for Cody, so I suspect he probably had a significant bleed or perhaps through a clot. But Cody was actually doing quite well until the very end, in fact, the last day. Is the vaccine available currently at our location pending approval from the USDA? The answer is yes. We've had some comments, and of course we have a Facebook page that indicates some people are getting their second vaccinations almost as we speak. The reason that is that the vaccine, one good thing about the vaccine is quite stable when refrigerated. So some of the clinics that have participated with us 4 or 5 or 6 months ago may have vaccine. We're no longer delivering vaccine to locations outside of Connecticut. But when we have delivered it months ago, they get both doses or even more than both doses. But we're no longer allowed to distribute the vaccine, but those that actually have already received it are the ones getting their second doses, for example. From Emily, anything we parents of dogs taking the vaccine can do to help me get the licenses I need? Moral support helps a lot, Emily. I'm getting roughed up a lot, both by some institutional people here at Yale, as well as elsewhere, that are keeping close watch of everything we're doing. I'm trying to do this, again, this is based on some conversations with both Stuart Helfand and Philip Bergman about navigating both the USDA and other strategies here. And hopefully our manuscript will be in the veterinary literature soon. I think the data is good. We continue to analyze individual subsets of patients. We thank Mari for her support, of course, and as she pointed out long ago, that really the value of social media that has allowed us access to literally field trials with this therapy is as good as it gets, to me at least, naively, in organizing a clinical trial like this. This is in the hands now of veterinarians that will be using this hopefully on a regular basis, and we're getting real data from real vets out there with real patients that show up in their offices with various stages of cancer, various genders, breeds of dogs, extent of disease. So to me, this has been a fantastic experience. It does keep me up at night. Many of you who are either existing patients or vets that use our therapy know to expect return emails from me pretty efficiently, either mostly the same day or two, if I happen to take the weekend off, at worst 3 days later, but sometimes you'll get emails from me at 2 in the morning. So I'm pretty immersed in this program. And again, thanks to all of you who don't accept conventional therapies for diseases that are pretty aggressive, like osteosarcoma, hemangio, and all of these tumor types that affect these dogs. Do I know if the USDA would allow a small, tightly controlled clinical trial to be run outside of Connecticut? I hope so. I plan to propose that to the USDA, Stuart. And I'm trying to establish a fraction of this trial again that will utilize vaccine prior to chemotherapy, prior to any surgery, with what is a presumed diagnosis of osteo or hemangiosarcoma, with the strategy that earlier therapy may be much better. Early immune-based therapy may increase our clinical outcomes relative to waiting after chemotherapy. From James, have we done any retrospective studies trying to determine vaccine success differentiators between successful tumor regression versus refractory patients? Yes, we are, as best we can, trying to navigate specific pathology. So for example, we're trying to, those are difficult questions to answer, as you can probably appreciate, because in part trying to get our hands on tumors that have been done in the original diagnosis or the original pathology that was done is oftentimes very difficult. Trying to extract tissues from the hands of commercial laboratories requires literally hours of communication between, and this is just with one particular commercial laboratory. But we're trying to get patients pre-enrolled and getting surgeons online to give us fractions or chunks of tumor that we can both extract and stain individual tumor cells, as well as following them prospectively throughout the course of their disease. So for example, this whole controversy of how much EGFR is expressed on an osteosarcoma, if we can do parallel studies specifically staining a patient that will or won't receive vaccine and that will or will not respond clinically with good outcomes to our vaccine, we have part of the original tumor, and we can follow whether that tumor expressed high, medium, or low levels of EGFR, both by protein and by messenger RNA, and we can correlate that with clinical outcome. This is how it's done in humans, obviously, and it's how we want it to be done in dogs. You guys are all welcome to actually speak questions if you want. You can unmute yourselves. I'm happy to have dialogue. Particularly interested in any vet oncologists out there with real experience in treating these patients, and frontline comments about what both families, moms and dads of patients with dogs want and how you treat them. I tend to find that many of the moms and dads who contact me say I know the vets are trying to be conservative in predicting outcomes in these diseases oftentimes, and I think that's reflected in some of the comments that get directed to me. From Kendra, can participants insist that their animal's tissue be sent directly to you when tumors are removed? Yes, please insist. we're trying to, again, in some of the vet offices that are referring many of their patients to me, and we're beginning to get more and more pre-vaccine or pre-chemotherapy tissues. Collectively, this is all contributing immensely to really understanding the biology and the therapeutic outcomes of this vaccine therapy. So we're slowly working our way into that question, Kendra. And I think as we get USDA approval, we'll revise our communications with individual vet offices that are using us, and hopefully vet schools that can provide these tissues before any therapies are instituted. Understandably, these tissues are in high demand. I'm not the only game out there that's doing clinical trials, of course, or that want these tissues, both for basic science or for clinically applied trials like this. These are highly sought after tissues. But strangely, at least to me, and perhaps because I'm outside the vet oncology circles, they've been a bit more difficult for me to acquire than perhaps I would like.
I believe there were some questions that were missed.
Either read them to me or point them out to me, perhaps. I've been trying to keep up.
I know, it came in fast at one point. Mary, do you know?
Did you answer the one about the natural killer cells?
Oh, no, I did not. I think I saw one, but I may have missed that. And I'm still missing it. We have not yet looked at natural killer cells, if that was part of the question. Again, the reason we're picking on this family of proteins is because successful human therapies have relied on monoclonal antibodies to components of EGFR and to HER2, in fact, to specific sites of these proteins. So again, I'm an immunologist that studied antibody-mediated diseases, as well as T-cell-mediated autoimmune diseases. So we've been trying, that was really the motivation and the strategy for picking on this tumor group. Fortunately, it happened to be a family of proteins that is expressed on a lot of dog tumors, of course. So it's clear that the best immune therapies may include CD8 or NK mediated tumor cell killing. But again, we are seeing CD8 T cell infiltration. We haven't yet done the fine specificity in knowing what peptides or what part of EGFR, or if it's EGFR at all, or other proteins that these T cell responses may be directed at. But again, relative to checkpoint mediated therapies that we would hope would be an adjunct to this vaccine therapy that we're investigating, I would think that this is going to be nothing but all additive. And there will be checkpoint inhibitor therapies in dogs. Probably, I don't know, maybe some of you out there know the status of the development of some of these. I would guess in the next year or two. This is just, it's been too important in the landscape of human tumor therapy. And it's really just time before it finds its way to dogs. Is immunocytin for hemangiosarcoma similar to this vaccine? No, it's not. But I haven't compared directly. You know, the investigators in that group of therapies, we don't collaborate. let's see. Blocking signaling, is there any NK cell mediated ADCC? And if so, could you augment efficacy with NK cell infusion? Mari, my suspicion is yes, is that there are therapies that seek to directly inject various therapies, be it T cell or chemotherapeutic strategies directly into tumor sites. Would systemic NK-mediated therapy work? I would bet not as well as we would hope. And certainly direct tumor challenge, which has been investigated in a number of trials and in a number of different therapies. While it's an attractive strategy, I think it is in practice much more difficult. Many of these tumors, as some of the vet oncologists here know, become highly encapsulated and very difficult to either get at with probes. It's just not that simple. But certainly direct injection of various therapeutic strategies being either immune checkpoint blockade or chemotherapies directly, nanoparticles that target tumor proteins or tumor immunity directly injected into tumors, cytokine mediated amplification of the tumor microenvironment. These are all things that work best when they are directly injected into the tumors. Again, it's just strategically a difficult thing to do. From Lori, can I comment on type 2 and type 1 immune responses in long-term memory? If you're asking in our particular patients to this particular vaccination, I really can't. We don't yet have the data. As it turns out, there are strengths and weaknesses to having both a local clinic managing this trial as well as far-off clinics. Far-off clinics, it's very difficult to get fresh cells, fresh peripheral blood cells to look at both type 1 and type 2 immune responses. That's most easily done when the clinic is 20 or 25 minutes away, which is the distance between our local clinic. And in fact, at times I have done that. And in fact, when there is a dog that has not survived and has willingly been donated for necropsy or post-mortem analysis in our clinic, I literally drive down there. I drop everything I'm doing in my office, drive 20 minutes away to get either tumors, whole dogs to bring back to Yale. I'm literally transporting them myself in hosts or tumor-bearing patients that are literally 20, 30 minutes post euthanized. So when I say we've looked at side effects in the dogs that have received our therapy, these are in freshly collected tissue samples. This, of course, is impossible to get from far-off clinics. So again, strengths and weaknesses of having both local and far-off clinics that are utilizing our therapy. Thanks for your kind words, Elizabeth. Yeah, we're working hard at this. I'm the dad of a cancer non-survivor. I know everything that the patients of our families are going through. I had to make those same decisions. And in fact, that was motivation for me even seeking these therapies. For those of you that may be interested, this study in dogs happened after a few glasses of wine at a party, a gathering here in Connecticut, where the host had cancer, as did his dog. The host did quite well, in fact, survived very well. The dog did not. I happened to meet Dr. Post at this gathering, and this is after we were completing our mouse studies, and I thought, this is perfect. So I have to say it was a wine beverage induced original thought that ever got me into studying dogs with cancer. And now I hope to never stop studying dogs with cancer. So that's how profound both this ongoing study, the original exposure to this and the ongoing study, and my own personal experience in studying dog cancers. And I will intend to never leave this field. Sorry, you guys got me for a long time, whether I'm wanted or not. I'm just gonna, it's gonna be here. Let's see. We may have, let's see, in the future of immunoside, and people who are producing and quite interested in collaborating with Dr. Mamula. Oops. Oh, that was for Elizabeth. Good. If they're interested in collaboration, all the better. I'm seeking, I never deny a collaborative interaction for those that can move the program forward. What do we need? Oh, great question from Amanda Smith. Formalin fixed tissue is perfect. So if we can get that from, that's something we can get from far off places. In fact, we do, is that surgical specimens thrown into formalin are perfect for what we do and need and what we can stain. So that is an easily done manipulation. We don't need much, a few centimeters, squared cubic centimeters of tissue. We are trained immunohistochemists. I have a cryostat within 20 feet of my office that we process our own samples, our own thin sections, and do our own immunohistochemistry, confocal microscopy. A suite is again within about another 40 feet of my lab. We have pretty sophisticated imaging and microscopy suites that allow us to do all sorts of really nice tissue staining. From James, it's known that human cancers produce immune downregulating chemokines or cytokines to suppress immune activity in the local tumor microenvironment. Are we encountering this in refractory canine patients also? My suspicion, James, is yes, this is happening. We're actively staining for checkpoints on canine cancers. So while antibodies are basically antibody-based therapies, whether it's Herceptin or Erbitux or even other antibodies, they largely ignore tumors that that express checkpoint inhibitors on their surface, or checkpoint which inhibit other T-cell mediated immune responses in the tumor microenvironment. Antibodies can seem to still do well, but you bring up a great point, which we hope to answer with real data, is in the patients that either don't do well or that are long-term survivors, what is the status of their checkpoint proteins on the surface of tumors? What is the status of other cell-based immune responses in the tumor microenvironment? If they resemble humans, as you predict, James, they will be secreting things like TGF-beta, IL-10, other cytokines that try and protect them and that try to enhance their survival. So yes, this will happen. They will probably downregulate canine major histocompatibility complex proteins. These are all traceable. I always love an experiment that we can do in the lab, and we can do any of these things. Of course, what we need are the tumors in a form that we can study them. So yes, we hope to correlate the survivors from the non-survivors with all of these parameters nicely characterized. I'm actually very interested in following up with these anecdotal studies. I call them anecdotal, but we've got real data about being fairly successful in lung metastases from osteosarcoma. So I'm actively recruiting, or when we are up and active again, I'm going to actively recruit patients with lung mets. Decalcification of bone biopsy has been reported to negatively affect detection of HER2. That's true, Stuart. Yes, you have to be very careful. In fact, this is true with a number of other proteins, tumor proteins, not just HER2. Do I think this is relevant to detecting EGFR, HER2 in canine samples? Absolutely, yes. Stuart is obviously tuned in to the nuances, the vagaries of staining tumors for this family of proteins. And osteosarcoma is particularly problematic because unlike other, quote, soft tumors where we can essentially plop them right down on machines that cut thin sections, that can't be done effectively with osteosarcomas. So both antigen retrieval and decalcification are tricks that enhance our ability to see these proteins, and yes, are all part of being accurate as laboratory scientists here. If any of you have questions to address to me after today's session ends, which may be soon, I don't know, Mari, it's up to you. Please send me an email, mark.mamula@yale.edu. I'm pretty easy to find if you Google me. I also answer my own phone.
He does. Well, thank you so much. Thank you so much, Dr. Mamula. I'll keep this. I don't know about your schedule, but I can keep this open for another 5-10 minutes if anyone wants to have a conversation with you. But really, we so much appreciate the work that you're doing and the time dedicated to this seminar. And I'll be posting the recording soon. And I don't know if you can make the slides available, but we can also make that available if you would like.
I'm very happy to mail you my slides. Hopefully this will be in the veterinary literature soon. Mm-hmm. So one can, go through the fine detail of what I may have glossed over too quickly in this presentation. I'm particularly interested in opinions about long-term survival. For the vet oncologists out there, I'll tell you one thing that really bothers me among the veterinary literature is predicting long-term outcome based on the time of initial diagnosis. To me, both in human and canine cancers, but particularly in canine cancers, because as we know, dogs don't express pain like humans do. My guess is that human cancers are diagnosed much more efficiently at the time of onset than are canine cancers. So my particular worry is that, of course, some canine cancers get osteosarcomas. The moms and the dads don't bring them in to offices to get diagnosed until long after they probably existed. So data like long-term survival based on initial diagnosis is, I worry, even in my own data, honestly, about the accuracy of original diagnoses of many of these cancers.
Thank you for everything.